let's move on to sort of more advanced disease, castrate-resistant disease. It used to be called androgen-independent, hormone refractory, and now it's castrate-resistant. Dan, what are your thoughts about that? That terminology, does it really matter? Does it make you feel comfortable or patients feel comfortable?
It's interesting you bring that up because I had a discussion with this about a patient on Monday this week, and he mentioned that he feels that castration resistant is a pejorative term. He doesn't like the term castrate, and I actually brought up the editorial that you and I wrote for JCO about endocrine resistant or primary endocrine resistant prostate cancer. Patients don't like that term, and they hate hearing the word castrate come back at them.
And resistant.
And resistant at the same time. So endocrine, I guess failure is not a word you want to use in front of a patient either, but endocrine resistant or endocrine progressive disease would be a better way of describing it.
So, I mean, that was all started just because that you still respond to, some of these new drugs like androgen biosynthesis inhibitors like Zytiga, abiraterone, which I sort of want to get into now because when these drugs were studied, and there's in the last 7 years there have been 5 new drugs, right? There's been abiraterone, and that was studied in Cougar 301 and 302, right? Pre and post chemo, and then we had radium come along, and that was a breakthrough. And then we have enzalutamide, and then we have Provenge and cabazitaxel. So we have 5 new drugs. They're all different. That's exciting. They're all different.
All different mechanisms, really 4 different mechanisms. When it comes down to it, you have hormonal agents, you have chemotherapeutic agents, you have immune agents, and then you have DNA damaging agents, which are radium. So we have different treatments to choose. The trouble is, how do we sequence them? That's really the big challenge for the urologist and oncologist, right?
Yeah. So let's focus on androgen biosynthesis inhibitors, Zytiga, abiraterone right now. That was one of the first breakthrough drugs. And what it did was teach us that, testosterone's king, and lowering it more, you had unexpected benefits that a lot of us didn't expect to see after chemotherapy, and that got that approved. All these drugs are moving up earlier now, right? I mean, where are we with the earliness, so to speak?
Well, right now, if we talk about early in the state of metastatic disease, docetaxel right now is the only one that has level 1 evidence. We know that there's about an 18-month improvement in survival.
Charted study, right?
From the charted study, right, showing for patients with high-volume disease, more than 4 lesions on bone scan or liver metastases. We're looking to move up drugs like abiraterone and enzalutamide into the same space. One would think that a more prolonged deprivation or more profound deprivation of testosterone would lead to better survival, but that hypothesis still needs to be tested.
So, these drugs are being studied in biochemical failure. Right. We just did a large trial called the Imagine trial. You moving abiraterone up in the pre-castrate resistant metastatic stage and have a prolonged survival rate. So, one of there's no question that they move up. And, one of these drugs all have pretty unique side effects. I mean, they're well tolerated. Right. This is all about shared care. But, sometimes, urologists are a little apprehensive about using some of these drugs because they worry about can I manage the side effects? And that's where the shared care comes in. So, let's talk about abiraterone, Zytiga. Pretty well tolerated drug, but, it says that we need to monitor potassium. We need to, and there's the reason for that occur. We need to look at liver enzymes. We need to look at blood pressure and things like that. So urologists say, well, we don't do that in our office. We don't draw blood. Is there a way to work with you guys with these?
Pick up the phone.
Yeah.
Just give me a call. We do this all the time. That's the interesting thing is, for example, talk about potassium. I mean, this is, if you're...
It scares urologists. Well, if the potassium's like 3.8, they go, oh my gosh.
Well, yeah.
That's not a worry.
It does scare you, and remember, this is what I do all the time. You know, we've had to deal with this recently with some other drugs that y'all use that will change blood pressure. Right, will affect it. Some of the medications we use for overactive bladder. Blood pressure doesn't scare me. If it's, just send them over. I mean, we have blood pressure cuffs. My guess is you don't have them as readily available.
We don't
in
know
your
what to
office.
use.
Yeah, I am okay with that. So, but I don't do what you do. So you call me up and we take care of it. I mean, I check potassium regularly on my patients on diuretics.
Right.
That's easy. I check their blood pressure periodically. I check liver enzymes for patients who are on drugs that may go, like the statin class drugs. We don't check it as frequently as we used to, but we're still aware of it. And then we take care of it. So when your SGOT or your SGPT are high, I take care of it. It doesn't do
So
anything.
that's a very good point. So like the diuretics, that you can get a low potassium, and we don't. Urologists know that, but they don't. That some of them are probably on the drugs.
Yeah.
They don't think that. In same way with statins, you just mentioned that with liver enzymes, and so these are things that happen.
Right.
And for example, with my biggest concern is with managing blood pressure, because often these patients have cardiovascular disease, have other multiple medications that they're on, and I will always call up the primary care doc or the cardiologist to be sure that the medication I want to increase is the right one, or to ask what their opinion is as to what's the proper medication to increase.
And there's a very easy answer on that that's actually easy on the patient. So if I'm making an adjustment, say for blood pressure, I'll tell the patient, come in once a week for 6 weeks. You don't see me, so they don't have that office charge. If your blood pressure is abnormal, the nurses are going to get you back, and we'll talk about it. So guess what? You can put them on the med, say, Matt, I want the blood pressure checked. We'll say, fine, just have them come in during the lunch hour, get their blood pressure checked, and if it's high, I'll see them. If not, we tell them they're in good shape.
So, and a lot of times these things are, at least in our EPIC system and electronic medical records, can be sort of routine in the treatment plan. We get a potassium every 2 weeks, and we get that. But, what I've done a lot of times with I treat a lot of guys from way far away, Wyoming, South Dakota, they're sort of being managed, and work with the primary care guy about checking the potassium and all those things, and it's fine. You don't be fearful, and I actually feel more comfortable having them take care of the total picture, as we've just been talking about.
And my guess is when you're seeing somebody in Denver and you're, but who lives in, Wyoming, you're contacting that primary care doc in one way or another and saying, and you're handing the baton off.
Right.
You're making sure that baton is grabbed by them and they're going to run with it. And that is so crucial to do that. And again, it doesn't seem like it's that hard to do, but for some reason we've gotten away from that. So if any of the urologists or any of the oncologists can just contact the doctor, make sure they are aware, we're happy to do it.
So, I mean, it is very important to discuss. Hey, we're putting this patient on abiraterone, and these are the things that every primary care doctor doesn't know what the drug is, but they find out, and then you get. I mean, the same thing when following something you're doing with chemo. They follow up with their family care guys, knowing about seizures with some of these drugs and things like that. It's all out there as a matter of education and that. And then it makes for a really happy situation when you're doing that with patients.